I don't like a lot of chiropractors. I've worked for plenty, but I've worked for orthos. I've worked for NDs, DOs. Not a lot of them were great, but there's good and bad in every industry. One of the reasons why I felt compelled to become a physician because I didn't really trust a lot of the doctors that I've seen in the past.
It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you.
Hello and welcome to the Desperate for a Diagnosis podcast. I am your host, Laura Nozica, and I'm here today with sports chiropractor Dr. Randy Cybulski. And this is cool because he's the first chiropractor that I've had on my show, and he has all kinds of unique perspectives on medicine and healing and fixing you, and he's going to talk all about that today. But Randy, Dr. Randy, right? Do you prefer Dr. Randy?
Dr. Randy's good. Laura, this is
Randy?
such a thrill. This is the Desperate for a Diagnosis podcast. This is pretty cool being in here. I appreciate it. This is a big thrill for me.
Thank you. Thank you. And Dr. Randy will tell you all about his background, but this is even cooler because I have to let all of you know that Dr. Randy and I went to grammar school together a million years ago here in the suburbs of Chicago. And because we were at a 40-year reunion not that long ago and got to talking about what we do for a living now. And here you are, which is so cool. We've come a long way, and I think we did okay for ourselves.
Definitely. I'm proud of you too. I mean,
Yeah.
just the idea of the name of your podcast, Desperate for a Diagnosis, it's almost like over the course of time, I've built my practice with that type of theory in mind. I've always been in sports. I played college football. I had a little stint in the NFL on the practice squads, played a little arena football, a little semi-pro. Then afterwards, my body had enough. I couldn't devote enough time to stay in the sport, once you start a family and all that. So I fell back on my degree and I worked at therapy places, all the commercial places that you can think of. I was a certified athletic trainer, rehab therapist. I've worked for ortho places. I got to meet a lot of professional athletes. That led me to an invite back around 2001. I was invited to help build and design this orthopedic rehab device for Hall of Fame pitcher Oral Hershiser. He, through his last game,
Name dropper.
yeah,
Name dropper.
I might have to do that a couple of times. So, but it was a cool experience. I was technically an assistant consultant to build this device. But the thing about it is, Oral, he's had numerous surgeries being a pitcher. And after his last surgery, some of the neural pathways going down to his right arm, since he was a right-handed pitcher, were compromised. Even though the surgery might have been successful, the neural pathways were not connecting to the brain. So shifting his car, doing little things, he had to look where his hand was in space to know where it was. If you put your hand behind you, you know where it is because it's talking to your brain. This particular device, I was working directly under physical therapist Kevin Wilk, who was one of the top physical therapists under Dr. James Andrews, renowned orthopedic surgeon. Now he's retired, but he was the best and the biggest orthopedic surgeon in the world. And we developed this device. It was called the Sports Rack. And
Sports rack.
yeah, SPORTSRAC. And it was it was put together by a couple of engineers out of Boulder, but they didn't know about rehab. So they brought in some experts, and I guess I was one of them. But we converted it to something that was considered very early intervention range of motion therapy. And we're talking, it was crude at the time, crude now, but at the time it was state of the art. It had a little cuff on it connected to a computer. The computer had this little ball. The ball wiggled on the screen, and you had to move the shoulder in a non-resistive motion. We're talking day one post-op that you don't incorporate any resistance, so there's no stress on the joint. So as the ball was on the screen, the algorithm was eventually taking the ball off the screen. And then every level, you go a little bit more, take the arm at different levels. There was an attachment for the Tommy John surgery in the wrist, a knee attachment. And after that, proprioception and balance coordination really came to the forefront of a lot of physical therapy. And that was one of my first introductions of things that were outside of the realm of normal physical therapy center curriculum, which is all based on stretch and exercise.
Mhm, mhm.
And I took that information and I took that experience and I worked for different ortho places and even chiro places. I got frustrated over the course of 19 and a half years working for doctors and places that everything was done very rudimentary. And I wanted to do more, and they teach you in school, everything, stretch and exercise. But they also teach us in school about inflammation, scar tissue production, muscle compensation, how your body handles that injury and that physical stress. And nobody's incorporating that, but you can't incorporate it unless you get the okay from the doctor. And how many times is there a doctor that's very knowledgeable about therapy?
Yeah.
So
You mean as you were working under a physician?
correct.
Yeah.
Yeah. And so that's when I decided at about 37 years old to go back to school to become a physician because I had an idea of what I wanted to do. Graduated as a chiropractic doctor in '09 and started my practice both in Plainfield and Highland Park. And if you know anything about Illinois, they're about 60 miles apart.
Yeah. Right.
In Highland Park, I was the director of sports medicine at a sports performance facility called EFT Sports Performance. And just about every Chicago Bear and a lot of professional athletes were training out of there. So it was it was a great experience. It was something to be able to treat some of the best athletes on the planet. And as I grew my other practice in Plainfield, I started to do that less and less. So then the athletes started to come see me.
Mhm.
And now I have a 8,000 square foot facility with 50 treatment rooms. My physical therapy center is got indoor turf. We have massage therapists, 13 employees. We're the single standing largest office in the state for sports chiropractic and physical therapy. It's also a medical center. And we have doctors, physical therapy, naturopathic doctors, sports chiropractors. My son's a chiropractor and he works there too. So
Oh my gosh, I can only imagine the dinner conversations.
well, as a matter of fact, we're going out to dinner with his family and me and the missus. So grandma and grandpa
That's
for
funny.
tomorrow. It's going to be
That's
awesome.
funny. That's funny. What's the name of your practice again?
It's called Pro Sports and Spinal Rehab.
Okay. Okay.
And we also have a medical practice called Pro Medical, where we incorporate platelet-rich plasma injections, PRP, as well as stem cell recruitment therapy. Amazing, amazing stuff. We do everything but the surgery.
That's so cool, Randy. And then I think you said you have a gym too, right?
I do. I'm the owner of Force Gym Naperville.
Yeah.
It's a 7,500 square foot fitness facility, and the idea of opening that up in 2020, our office works with a lot of sports programs, and sometimes we're seeing young athletes, and some of these young athletes, it gets to the point where some of their injuries are nothing more than lack of durability. And there's hockey programs, baseball programs, football programs where a lot of the off field or off ice activities is a lot of speed and agility, which is good, but they're not incorporating strength,
Hmm.
and study after study has already shown that there's no detriment on growth plates if there's strength involved, as long as they're monitored. So that's one of the reasons why we started the gym in Naperville. Since then, it's grown to like a awesome membership and we do training in there. And the great thing about that gym is the individuals running the gym and running all the training are actually chiropractors.
Oh, very cool. Well, talk about being proud of you. You've done a ton, and I think it's great that you found your niche, found your passion, you redirected, and I think that's really cool that you're doing all that you're doing. I have to come visit one of these days too and check it all out.
Absolutely.
Yeah, but so I'll be honest, I've been to a chiropractor, I think maybe once or twice. And it freaks me out a little bit when I think a lot of people think, oh, chiropractic care are just a bunch of bone crackers, right? And, and I think there's some misperceptions out there of what chiropractic care is. So if you could, Dr. Randy, kick us off and tell us a little bit what some of those myths and maybe misconceptions are about chiropractic care, and let's set the record straight.
Now, from my perspective, I'm a sports chiropractor, which is as I'm a board certified sports physician. It is additional schooling,
Okay.
but we become more experts on biomechanics. In my opinion, every chiropractor should be a sports chiropractor. It's you get to learn more about the whole biomechanic portion of the body. Every 5 years, we have to have a certain amount of continuing education. So that is an amazing background to be able to have that. Now, I don't like a lot of chiropractors. I've worked for plenty, but I've worked for orthos. I've worked for NDs, DOs. Not a lot of them were great, but there's good and bad in every industry. One of the reasons why I felt compelled to become a physician, because I didn't really trust a lot of the doctors that I've seen in the past. Now, when it comes to chiropractic, the adjustment is basically about structure from a sports chiropractic standpoint. And I always recommend to see a sports chiropractor. Now, the adjustment is great and all, and I get it. I get the benefits of it, but it comes down to giving you motion you don't have, correcting your motion, or maintaining it. All of your symptoms are coming from your soft tissue. So the soft tissue has to be addressed. People come in with injuries all the time, musculoskeletal, extremity, spine. And if we're going to incorporate the chiropractic adjustment, it's only part of the therapy. Unfortunately, there's a lot of places where, that's how they base their therapy. And some of these commercial places that, without naming any, they approach us in school. They approach the young chiropractors getting ready to come out, and they make it sound very lucrative. I know I've been approached. We've all been approached, but you have to treat the way they want you to treat. And anybody, for what they do, it does help some people, but why are you doing the same thing on everyone? And for a lot of people, they'll see some temporary relief, and then they'll start to do things and start visit more and more, which in reality, that's how some of them have to make money. I don't agree with that, but especially when you're dealing with adjustments on a regular basis, we see a lot of patients that have been frustrated from other places that are near me that finally come to us, and we're like, yeah, don't worry, we're not going to do that. But the important part of manipulating the spine is there's really no difference in when you wake up in the morning and stretch and hear that crack and pop. That's just air releasing from a joint. You do it in your knuckles. People do it in their neck all the time. When it comes to the adjustment, it's very much about creating a motion in the structure of your spine. And anything can be adjusted. It can be your wrist. It could be your ankle. However, if you sprain your ankle and you see a chiropractor, not all chiropractors, one of the first things that they may do is adjust the ankle. Well, you have ankle hypermobility. Why would you want to increase more mobility in that ankle? At some point, you would mobilize the ankle, just like at some point you would mobilize the spine and then those joints. But really what moves is a lot of the soft tissue, and the amount of thrust that goes into what we do is very little. Now, there's a lot of physicians out there that will poo-poo the idea about chiropractic, but it's funny how they talk bad about something they know nothing about. Or maybe they had a bad experience of someone they've had in the past, or someone that whose sister's brother's cousin had a bad experience, or they read an article about something or other. It's pretty difficult to be injured from a chiropractic adjustment. It takes a tremendous amount of force for something to drastically happen.
Yeah, because I've heard stories where people claim that they became paralyzed after an adjustment, which is very scary to think about. But yeah, I hear these stories all the time.
Yeah, and you'll also hear about, say, a stroke or a TIA,
Right.
but they don't take into account the fact that what was building that stroke up, and maybe it was just a ticking time bomb.
Hmm.
Those are all things that need to be considered. But patients also need to consider the fact that doctors should tell patients that number one cause of most deaths in this country, misdiagnosis of prescription medication.
Sure.
So, make sure that anywhere you go, any person you see, whether they're natural or allopathic, you have to feel comfortable with them. And you got to have a good gut feeling about them. If your gut says no way, you usually got to listen to your gut because your gut's usually right.
Yeah, 100%.
But hey, here's the thing. A lot of people don't question the authority. I always recommend to my patients, question the authority. That's why on their first visit, I'm listening to them why they're there. I'm going to tell them, here's how your body's handling this. Here's what's going on. Here's what I want you to do in the future for anything else. Now, here's how we're going to fix it. But if more doctors did that, people would feel more comfortable and in knowing what's going to happen next. But usually, they're trusting the expert to be the expert. And sometimes the expert is not always honest with them.
Yeah, understood. There's something to be said for, right, listening to your gut and listening to your intuition. Or when you've gotten, and I've gone through this myself, where I sprained my ankle terribly a few years ago, and I was continuing to go to physical therapy at the recommendation of a podiatrist. And honestly, I felt like things were getting worse. So I moved on to a sports medicine doctor and found an amazing physical therapist who fixed me, basically. But you really have to stop and think, okay, I'm not.
That's a great story because we see a lot of people that come in for foot issues and they've seen their podiatrist. And one of the first things that podiatrist does is cortisone injection, some type of procedure, and, may put them in a boot, and maybe not even recommend therapy. I'm not against cortisone. Cortisone is great. I love cortisone. My body responds very well to it. But I think one of the reasons why people don't respond to cortisone, that's a chemical anti-inflammatory. That if you're going to get therapy, like very much like the therapy that we do is very anti-inflammatory. That's a mechanical anti-inflammatory treatment. Now,
What's an example? What would be an example of that?
So when people come into my office, I explain to them, first of all, how their body is handling the injury. And when it comes to the musculoskeletal system, we are very simple structure. Okay. Our body's response to any physical stress is always inflammatory. You can't stop it. You can control it a little bit, but you cannot stop it from occurring. Now, once that inflammatory response is happening, whether you perceive it or not, your scar tissue is going to start to get produced. Scar tissue is adhesions. Or if you strain a fiber, muscle, tendon, ligament, cartilage, every soft tissue fiber is a nice linear fiber under an electron microscope. Now, the difference between that and scar tissue, you're looking at something that is the consistency of a bird's nest. So your brain is going to trigger the production of it to adapt to that little strange sprain, which is technically a little tear. So your body remodels the area, doesn't use the original substance. Technically, it's waste products. Those lay down, or they get laid down right by where the pain generator is. Could be a strain, inflammation, or disc, whatever. Now you have adhesions, and those adhesions will cover all of the soft tissue. The whole soft tissue is riddled with it. Okay. Here's the worst part. If you're talking about one body part, all of your joints have local stabilizing fibers, and then they have fibers that are responsible for movement. The stabilizing fibers are on 24/7. They hold a joint in place. They're doing their job. You don't control them. You do control the ones that move that joint for voluntary motion. Your brain perceives an issue, shuts down the signal to the local fibers. It's a defense mechanism. Plus, they're the ones that get shut down. They're right up against the pain generator. Now, if they're shut down, the only fibers readily for stability are your primary movers. So now you have volunteer muscle movers that are now trying to act as stabilizers. It's not their job. They're not going to last very long. And that's called muscle compensation. The problem with that is that can be going on for months before we even know that there's an issue. And it'll last years. And the reason being, because when it comes to the musculoskeletal system, we're injured one of three ways. Trauma, you hyperextend something, or it's overuse. And that overuse can include muscle imbalances, posture, biomechanics.
Yep.
So if, somebody comes to me because they saw their podiatrist and they did this and well, it didn't work. I'm like, well, let's do the anti-inflammatory mechanical therapy. And It could be anywhere from cold laser, hot laser, uh, different forms of electrical muscle stimulation that a lot of places do, but they underutilize it. Soft tissue mobilization, um, acupuncture, infrared, whatever, anything and everything. Because that's one of the things I tell my patients, that we're going to treat you, but I don't know if the therapy is going to help you until we see if it helps you. And if it doesn't help you, we're going to change your therapy.
Mhm.
Well, what place does that every visit?
Yeah.
And that patient has to respond. So if they come in because they got a bad taste in their mouth from that last podiatrist, let's do this. And if you plateau out or you're not responding from the mechanical anti-inflammatory, now it's time for the chemical. Okay. You're not going to take anabolic steroids if you've never been to the gym. Go to the gym, build up your muscles. Then when you plateau out, then take it. I don't advise that, but as a
Well,
hypothetical,
it sounds like you have a lot of tools in the toolkit, which patients are lucky that you think that broadly in terms of what is available out there. There's so much, and I've, as you know, I also do market research for a living, and some of the studies that I've worked on have been around chronic pain, low back pain primarily. But why do you think chronic pain, whether it's localized, generalized, whatever it might be, why do you think it is so hard to to combat or to help patients get some relief? And what's your sense of what's causing this chronic pain? Because there's so many people walking around, this hurts, that hurts. Everyone's hopped up on ibuprofen or whatever, Tylenol, whatever it is. And then when that doesn't work, they're looking for other things. So, what's your take on chronic pain and why it's so prevalent?
incredible question. And a lot of physicians and people will have the notion that chronic pain is difficult. It's really not. If you recognize how your body is handling this injury, whether it's acute, subacute, or chronic, the pain, there's only two reasons for pain. Inflammation, something's occupying space, or a nerve that's being excited. There's really no other reason for pain. I've seen athletes tear ACLs in their knee and there's no pain. They may have instability, but the pain doesn't show up until the swelling happens. Sometimes that swelling and that inflammatory response is very low. So as adults, what do? We either ignore it or we don't even perceive it, but our brain perceives it and it will start the production of scar tissue and a muscle compensation without us even knowing. Now, whether it's an acute or chronic condition, that it would, since it's the musculoskeletal system, it would have to be treated very similarly. Anti-inflammatory, scar tissue breakup, waking up the fibers that have gone dormant. And you can do that for something that's been around for years. You can also do it for something that's been around very acutely. The problem is most places just don't do that. If they did, the whole industry would be uniform. And what we do, everybody would do. But we have to do that because a lot of our clientele is professional athletes. And when the pros get hurt, they are expensive commodities. So they get access to places that do things aggressively, creatively, and sometimes alternatively. So that's us. But we do that on everybody. Now, a lot of places don't do that. And it's one of the things I found out very early after I went from place to place, therapy place after therapy place, because all we used to do was stretch and exercise. Now, that's all you do to treat. And if something is chronic, whether it's acute or chronic, you're probably not going to get better because your body's already compensating. So now you go to physical therapy, they do a lot of stretch and exercise. All of a sudden, you're compensating more. How do people get better? A lot of people don't, So because the way that their body's handling the injury or has been handling the injury has not been addressed. Now, it may take a few other visits, but here's the thing, and I tell this to everybody. If, number one, you don't respond to the first treatment, we're going to change your treatment. And we may go through 2, 3, 4, 5 visits and you're no better. But we're changing that therapy around every single time. And we're not going to wait for them to get better. Because I found out very early why everything was based on stretch and exercise. Finally found out that it was the physical therapy exercise codes. That's what's paid by insurance within 3 business days without having to submit documentation. So they all focus on it. And all these smaller operations will open up their practice based on how big boys do it. And it's all based on that. You have to address how your body's handling the injury. And it doesn't matter whether you've had it for 20 years or you've had it for 20 hours. Your body should respond. Now, if you don't respond, which sometimes people don't respond, well, then it's the next step, either imaging, we get an ortho involved. And that's another benefit of being a patient at our practice. Doing this, at least being in the industry for over 30 years, I have a good network of doctors. I know a lot of surgeons, but I only trust a few.
Mm.
As a physician, I'm very difficult to deal with another physician. Patients, I'm a chameleon. We work with everybody, but, experts call themselves experts, but they're not always the expert on what they're talking about. So the ones that I trust are the ones that know their role with me in my office. And I'm not trying to be something I'm not. I'm not trying to talk over something that I don't know about. But if it's something that we're pretty sure about and we've had good success with, then we're going to fight like hell to make sure that patient gets the care that they need.
Yeah.
And sometimes that surgery is necessary.
Yeah. Did you say, as we were chatting at the reunion, over cocktails and talking about, basketball games and cheerleading and what we did to teachers behind their backs. Did you say that arthritis is a finding and not a diagnosis? Do I remember that correctly?
You got a great memory.
Okay.
That's one thing that bugs me all the time, because patients come see us. A lot of them happen to come see us because they're so frustrated with other care and other physicians. So arthritis is thrown around a lot. Now,
Because when we talk about chronic pain,
mhm,
arthritis is right up there. And then, of course, we ladies have osteoarthritis and osteoporosis and osteo and just the bones are creaking after a
mhm.
certain point in life. But arthritis just seems to be so prevalent. And depending on what you watch on TV and what channels you watch, that's what they're talking about. This supplement for arthritis and this fixes this pain and that pain. It's just a potpourri of stuff that doesn't work, I think.
And a potpourri of pharmaceutical commercials. That is, every commercial you see is now, every time that there's a commercial, there's a pharmaceutical commercial. That's crazy. Here's the thing. Arthritis is thrown around way too much by physicians, especially with chronic conditions. Oh, you have arthritis, sir. Well, look at the definition of arthritis. Arthritis. First of all, anything that ends in itis is inflammation. The art portion of the word means joint. So it means your joint's inflamed. So doctor, you're telling me my joint's inflamed. Okay, why? So too many times doctors are using that as a diagnosis when it's not a diagnosis, it's a finding. So it looks like your joint's inflamed. Well, then the 8-year-old gymnast that sees us because she hurt her hip, that hip's inflamed, that joint's inflamed. Does she have arthritis? Absolutely. What's the reason for it? There are so many doctors out there that use things that I don't know if they think people are stupid or they just don't know. And if that's the case, they need to be honest with people, because on the other end of the spectrum, you may bring your kid into the pediatrician because of some injury, and all of a sudden the doctor is going to tell the parent, oh, he's got growing pains. Growing pains? Okay, so, why? Because he hit a growth spurt? Well, what about the 20 other kids on his team that hit the same growth spurt and they're not in pain? If there is pain is due to some form of inflammatory response. Now, that could be muscle imbalances, and that's very common in children. They can grow quickly, but the reason for that inflammation, that muscle is tight or there's a muscle imbalance, it's going to cause some type of friction. The friction causes inflammation. Inflammation is your pain. Okay. Don't just accept. And that's why I love being on this podcast, because people would, if they're listening to you, they are desperate for something else. They're desperate for some answers. Okay. Desperate for a diagnosis is the beginning portion of why people want to listen to something like this, because just the name of your podcast is amazing, because people need answers, and they also should always question their authority. So if you're a parent and you're going to see your kid's pediatrician, they say it's growing pains. Okay, why, doc? Or if you're going to see your physician and he says, well, you have arthritis. Okay, from what? What's the reason for the arthritis?
Yeah.
Everybody's joint gets inflamed due to physical stress. Now, the fact of the matter is, as we get older, it's a lot easier for us to feel pain because the inflammatory response just happens a lot easier. That's why youth is wasted on the young.
Say it again. Say it again, Randy.
Youth is way too much wasted on the young.
Freak.
So, and that's the thing. If physicians were more honest with patients, even if it means I'm not sure I'm the one who can treat you or even diagnose you, but they're not going to do that. They're going to treat in the tunnel that they are familiar with. When being in this industry, and I'll give you a perfect example. If you're working for an ortho and say there's an ACL that needs to be repaired in the knee, well, there's 4 ways to repair that. But the ortho, you're going to sit there and say, here's what we're going to do, sir. We're going to take, a piece of your patellar tendon, we'll reattach it, we'll attach it here, this, then the other, goes through all the steps. Well, what if the ortho actually told the patient, there's 4 ways that this can be repaired. I only am certified in 1. So feel free to go investigate the others if you truly want me to continue. This is the way I do it. This is why I do it. But they're not going to. They learn how to do it one way, or they're comfortable doing it one way, and that's how they do it for everyone. But now you're dealing with another cookie cutter type of therapy, whether it's a surgery or it's physical therapy. You can't, people are not cookie cutters. Every patient is different. And, and unfortunately, there's a lot of people that will go to either some of these therapy places still, or some of these commercial chiropractic offices, and they are sitting there, they're watching those other people doing the same therapy that they're doing. Now, granted, it'll work on some people, but why wouldn't they ask the question, Doc, how come I'm doing the same thing that those 5 other people are doing?
Because you're all in the same room with everybody. I've gone to the chains that you're referring to, and you lay there on the table with 2 other people next to you, and you're all doing the same leg raises and whatever else.
Maybe it's the crowd mentality. I mean, there are still people that join cults, for crying out loud. We need more people that question their authority.
That's right. And then you're prepaying for your, 12 visits or whatever insurance approved, whatever it is. But
Yes.
But pain, I've interviewed a few patients on the podcast too, and one in particular, she has just had this chronic generalized pain for so long, and I contacted her recently. I interviewed her over a year ago and contacted her recently to see how she's doing, and she's still having this all over pain, and at some point, as a physician, you get to the point with patients who just they never improve. And do you have any suspicion that maybe there's something else is going on, that their pain is manifesting the way it is, but there's no one centralized point of pain? Like, you can't figure out where it's coming from. It's just this generalized.
Well, you can't rule out anything. Psychosomatic pain is a real thing.
Mhm.
Now, we have a lot of patients. I've seen a lot of patients that over the course of years, they're just so used to hearing the doctor say, well, there's nothing that I can do. There's nothing more we can do. You saw the pain doctor. You did this. There's nothing more we can do. Might as well just do hospice then, for crying out loud.
You've
And
been
that's
on all
someone-
you've been on all the drugs, you've had the injections, you've been to therapy.
Or here's a new drug for you to take along with your other drugs.
Right.
And it's not until someone tells them, hey, you know what, go try this. That's why in my office, we don't advertise. And one of the first questions I ask new patients that come in, and I'll see anywhere from 275 to 300 patient visits every week.
That's amazing.
Super busy. And it's, if you have a big place, you can do that. It's not just we don't run people through. I mean, everybody's there for about 45 minutes to an hour.
Wow.
But some of these people are so used to just hearing that, and someone else who has been here and been in our office and have gotten success, or at least we've tried our best and thrown everything at that person, whether it was successful or not, they're going to tell that next person, and as a matter of fact, 10 other people, hey, go try them. So a lot of what we see is a lot of word of mouth. Our office does work with sports program with the official sports medicine provider, but a lot of people nowadays are word of mouth in our office. And the other part is these people are coming from Google searches. Now, when you go on Google and you put in the search terms, any one of the 17 offices in my 5-mile radius around my office will use the same search terms. However, if we're all using the same search term, sometimes Google has you at the top of the page, sometimes you're at the bottom of the page. But we have a lot of good reviews, so enough people think we know what we're doing, so they happen to keep us at the top of the page without having to be a sponsor of the page.
Yeah.
If you have to pay to get to yourself to be at the top of the page, I'm old school. Right? I grew up in Berwyn, just like you, just outside the city of Chicago. So I have
The home
right.
of Spenguli, as they claim, right? Right.
That's right. I used to tell people that too. And I actually moved to Florida while I was in high school. And I'm like, yeah, I heard of Svengoolie. They're like, who? Oh, I guess you didn't watch that documentary.
Yeah, unless you were raised in the area, Berwyn, Cicero area, they don't know who Spenguli was, but yeah,
Excellent.
he liked Berwyn, and didn't he walk the Hobie Parade?
Every year.
Yeah, yeah.
Every year, and that was his joke, is every time that he mentioned the the name of our town, Berwyn.
Berwyn, yeah, it's
The
great.
best, man.
That's awesome. but but yeah, so you're saying you're old school.
Yeah, and it kind of breaks my heart a little bit when you hear these people come in and they're being told, well, there's nothing we can do. Well, I'll be honest with you. And I'll even tell people, I'm not sure if we can help you, but what we do, you haven't done. So
Mm.
let's give it a try. Make sure you do the things outside of therapy that we have you do. And it's usually they come in, they get their own ice pack. We give them one to take home. And then they come in with misconceptions also from healthcare providers of like, hey, I was told to use heat on something. And just so everybody knows, you don't necessarily heat when you have an injury. The first sign of any discomfort, I don't care what it is, you feel pain, always ice it 10, 12 minutes at a time, not 20, 30 minutes,
Mm.
10, 12, and you repeat it, you give it a day. And if your pain after about that day goes away, a lot of what you're experiencing is a inflammatory response. You may have just gotten ahead of that injury. You could be good to go. If you're good with ice and you give it a day or so, and that pain is still there, well, it's more than inflammation. Now you got to get in. All right, get it seen quickly, because what most adults do is they deal with it because it's not all that bad. And all of a sudden, a couple weeks or a couple months goes by, and all of a sudden you're making time.
Oh my gosh, I'm laughing because going back to my ankle story is and as you know, I ballroom dance for a hobby, but I've sprained my ankles 2 and 3 times each, either dancing or sadly just walking. And this last time it happened, I was walking down my stairs in the house with running shoes on, so it wasn't like I was barefoot or had socks on, and I just landed on a step funny, and this time I actually heard my right ankle go, like I heard and I didn't break anything, but it was awful. It was terrible. And so, yeah, did the ice, did the whole thing. I think I even went to immediate care just to get it sprayed right away, just to at least get a break out of the way,
Well, that sound scares you too, because you not only hear it, you feel it.
Oh, yeah, I think I was ready to pass out because it sounded terrible and it felt even worse, really. But I put ice on it, and I did wait over a week to go see the podiatrist who's part of his big ortho practice that I have experience with. But um,
That's funny, because the ankle, when people sprain ankles, that's a very common, because that, and it happens especially with young athletes. They'll sprain the ankle within a few days.
I'm no athlete, Dr.
Come on, man. You're a ballroom dancer. You're probably more active than some of the.
Who's an old girl?
Yeah, but that's the thing. Even foot doctors and orthos, a lot of times they're not going to incorporate therapy or even recommend it. And time again, especially for ankle injuries, especially if you're younger, you'll start to feel better quickly. Okay, so the pain level starts to go. Your inflammatory response is lowering. The problem still remains. And what is never really emphasized, except for our office, we get right into the anti-inflammatory therapy, scar tissue breakup, waking up the fibers. But then we even wait to do the exercises until everything is woken up. And then we incorporate the exercises, because within about 2 weeks, any soft tissue fiber that shuts down, even the ones that are designed for stability, atrophy will set in. So when you stretch soft tissue, like when you hyperextend an ankle, and all of your tendons are like rubber bands, okay? And you use the term tendonitis. Anything that's tendonitis is inflammation. So think about a rubber band in inflammatory fluid. Now, the difference between tendonitis and tendinosis. Now take that rubber band out of the freezer, stretch it. It doesn't bounce back. Probably frays a little bit, kind of like old shipping rope, but you're not really in pain. So you go about your daily life, 6 months later, a year later, all of a sudden you're doing something very trivial, roll it. Boom. Okay, it's not stable because the proper therapy wasn't done, but the proper therapy was usually never recommended.
Yeah. Yeah. Well, and he right away got me into PT, but after a few weeks, I started feeling better. And I started going out walking with my mom, not super far, but I felt like I like to walk. So that's what we did. And so when my ankle started feeling not so great, and I felt like it was because of the PT was making it worse. So I got back in and I told him I started walking, and he freaked out and said, "Why are you doing that? You should not be walking." And I said, "But I felt good." But after a PT session, I did not feel good, and finally he got me in for an MRI, and I had bone bruising. I sprained Can you sprain the deltoid ligament on the
Oh,
ins
yes. Deltoid ligament on the inside of that ankle is a much more severe injury than the outside ligaments.
I know, I'm like a rock star. I had a few people ask me who know about the deltoid ligament. They said, "What were you doing?" And I really wanted to just say I was, like, on vacation dancing on a bar just so I could have a better story versus I was walking in my house. But excuse me.
That's the misconception because we go to physical therapy and a lot of what they do is stretch and exercise. Now, if your body is dealing with the injury, yes, there's inflammation, there's your pain, the scar tissue production, there's the adhesions, and now you got your muscle compensation. If you start physical therapy and a lot of what they do is stretch and exercise, now you're going to compensate more. First of all, your brain will do whatever it takes to not feel pain. So if it means shutting other fibers down or waking other ones up to not feel the pain, guess what? And a lot of early parts of that physical therapy, because it's stretch and exercise, is helping you compensate better. So you're actually compensating more. You have to do, and that's the reason why, well, I felt better. And then I went for a walk and all of a sudden, and then you go on vacation. People feel better. 6 months later, to go on vacation on the beach or walking on the sand. The next day, they can't walk.
Mm.
That's a common thing that we hear too. I'm like, well, what type of therapy did they have? Well, I went to so-and-so and we did this. And it's the same tune, the same thing. Doing what we do, my place isn't, we're successful. It's not big because I have brand new philosophies. Okay. Honestly, I'm not that smart. Okay. We just work hard. We do things very logically.
I'm not sure about that.
Well, I know a lot. I know enough about a lot of things, but if it's something I don't know anything about, I always, defer to the experts. And if it doesn't gel, then I'll question the authority. But that's the thing. If it's something I know about, then you're going to hear it. And, I'm glad you brought up that, an ankle injury, because that we see that so many times from people who have had therapy in the past and will say, well, the physical therapy didn't work, or yeah, that shot didn't work. Well, because the succession of things that happened was not the proper way of doing it,
Mhm.
and as patients are listening to me, on the first visit, just telling them, here's what happened with that. Here's what you can expect. Here's what's going on. And here's what will probably happen. Now they're educated. So there's sometimes their next injury where we might not see them right away because they got it in time. Not that we don't love seeing our patients. We love seeing our patients, but if I give them the knowledge, at least something that they can take care of their body, well, I think that holds a lot of weight.
Mhm.
Then now that patient is more inclined to tell other people, hey, go there, because I think they know what they're doing.
Yeah, 100%. Well, I was very lucky that I found a brilliant physical therapist, Philip, and I actually would like for the two of you to meet at some point because he does things very out of the box. He doesn't work for one of the big chains, and he's very smart. So yeah,
Lucky.
need to get that introduction at some point. But Dr. Randy, what are some of the I'll just put it out there. Some of the more bizarre cases that you've seen where maybe a patient has seen a lot of different providers and has gone through a lot of different, maybe alternative modalities, whatnot, and after I don't know how long, even say even a year, They're just not better, but you saw them and you were able to help them. But and so what I'm curious about is trying to understand why patients do get passed around, bounced around to different physicians and just can't get an answer, and they come to you, and maybe they do have something just so bizarre and weird, but you were able to figure it out. What's your take on situations like that? Or tell us about a couple cases.
Wow. The timing is impeccable. We had a young athlete just 3 days ago came in with low back pain. And if it's one thing, low back pain, a lot of places will just start the treatment. Now, and my son caught this. So he's a relatively new doctor and he's amazing. So he's one of the physicians at the practice, and he decided to do, hey, let's just do a meningitis test. And the kid lit up and he was positive, textbook for meningitis. Right then and there, we sent him right to the ER. We called the ER and said, hey, we need this is who's coming. And sure enough, a young 16-year-old athlete was diagnosed with meningitis.
Oh my gosh. So what's that test like? What does that involve?
So there's a test that you do when you're flexing the neck or you're turning, and then there's an issue that you're going to start to feel either pain in the knee. That's one test. There's flossing when you're dealing, because anytime that there's meningitis, that's inflammation of the meninges of the central nervous system. So if there's inflammation there, that can easily manifest itself as low back pain or mid back pain, even neck pain. But if you don't just go through all those little steps just to rule that out, we never would have found something like that.
That's
And
incredible. Had he seen other providers?
no, it came on relatively, and he's a football player.
Okay.
So mom and dad didn't think anything of it.
Yeah, yeah.
Not only that, in actually about a year ago, we had a baseball player that had immediate pain after throwing long toss. He's a pitcher. And mom and dad went to quick care. They took x-rays, no fracture. They then went to, because they recommended to go to an ortho, went to hospital. Hospital took x-rays of the same elbow and was read by a pediatric ortho, no fracture. Well, they came into us. We did a visit, maybe 2 visits for the elbow, and something wasn't right. He was inflamed. I mean, the only other possibility of what could be going on was something was completely lacerated, but it was some pathological issue. So I texted one of the orthos I trust, sent him there because parents came in with 2 x-ray reports negative for fracture. So that ortho, luckily, he's seen something like that in the past and decided to do an x-ray of the humerus and found a spiral fracture in that arm.
Wow.
Now, 2 allopathic physicians and a pediatric ortho didn't think enough to open up the collimation on the picture, because anytime if it's a young athlete and you're taking a picture of a particular joint, always go halfway up, halfway down the opposite bones. That's like step 1, okay, day 1. And they didn't. And that fracture happened just after the 40% distance. And sure enough, he saw it, got him in for emergency surgery, pinned it down, and he was better. Not only that, myself and the ortho, we were so mad at that particular ER and those orthos, like they wouldn't think to do that. Now that's just musculoskeletal. We'll have a patient that comes in with, say, fibromyalgia. That's difficult to treat because
That's
now you're
hard.
deep.
Yeah. So when you talk about, I love talking about, well, I call it the weird stuff, but fibromyalgia is just one of those broad, like chronic fatigue syndrome. It's a syndrome. And when you hear that syndrome, it's like, we don't really know what it is, but we're chuckle something.
Thank you for reminding me. And one other example, I had a young cheerleader. She was diagnosed at 2 children's hospitals with chronic regional pain syndrome. And she had pain in her foot, feet, and ankles. And that didn't gel, because if you have chronic regional pain syndrome and you're 15 years old and you're a cheerleader and a tumbler, competitive cheerleader, you're not really going to be able to compete at really any level, if you think about it, because it's all going to generate pain. So, and it turned out that while talking to mom and dad, the second children's hospital, famous children's hospital, because they went for a second opinion, all they did was grab the past medical history from the last children's hospital, didn't do anything as far as new testing or whatever, and just gave her that diagnosis of chronic regional pain syndrome. Well, mom brought her little brother in, because we were treating him, and she's like, you know what? Let me just bring her in. So we started talking, and I'm like, and the girl was on the table. I'm like, do me a favor, show me one of your tumbling moves. And she was like, "Bup, bup, 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 bup." I'm like, and you're diagnosed with chronic regional pain syndrome? Turns out all she really had was chronic ankle spraining.
Nice.
And that was never taken care of. It was never, treated. They saw a pediatric podiatrist. No therapy was done. They put her in a boot for 5 weeks
Roar.
and a boot on the other ankle for 5 weeks. And of course, she felt better because she wasn't using it. And then she still had pain over the course of time. Well, we started her on a regimen of anti-inflammatory therapy, scar tissue breakup, waking up the fibers as we do. And all of a sudden, she started to feel better. Yeah, she's got some pain here and there, but that chronic regional pain syndrome diagnosis
Oh,
was just, it frustrates me to have to say it, but it was a cop out,
yeah.
you know?
That
Now,
that's crazy. And Randy, just to go back to the patient with the meningitis. So your son picked up on the signs, and you did the test. And did you say that the patient then was sent to the ER?
yeah,
Oh,
we told them to go to the ER, and because they needed to have, you need some imaging, different types of imaging. So we called the ER and, let them know what was found. And sure enough, and then they could do the blood test right there.
yeah.
And yeah, came back. Dad called us up and thanked us.
That's
So
incredible.
yeah,
That's
and that
amazing.
was my son that caught that. I wish I could say
Uh, that's so cool. Well, he's
he was
got
awesome.
a good teacher. You were starting to talk about the patient with fibromyalgia.
Yeah, anybody that comes in with that type of pain. So you have to, because everything that we do is all musculoskeletal in nature. I'm almost to the point where I have to tell the patient, look, we're going to treat you musculoskeletal wise. And if your pain is coming from the musculoskeletal system, you should respond. Now, unfortunately, when it comes to fibromyalgia or even migraines, you can have cardiovascular elements, you can have neurological elements, you can have hormonal elements to reasons for pain. It
Mm.
could be as simple as a coping mechanism, fight or flight, and that's the reason for, overall pain in the body. It's still an evolving science. And it's hard to wrap your head around what all that goes around with it, because just the idea of what pain, the way you experience pain, the way I experience pain are different. And it's very unique. Okay. And if you're, as a side note, when you see a physician and they start taking pictures and they start pointing, well, here's a reason for your pain. Um, how many times do they see bone spurs or a disc bulge or whatever? Oh, there's a reason for your pain. The reality is that patient's going to experience pain. You know, if I have a tear in my labrum, which I do, and herniated disc in my back, why am I not in pain?
Uh-huh.
But my images will show pain, but that doctor would be like, I can't believe you're not in more pain, or you should be in more pain, or I can't believe you're feeling great. How about instead of saying that, and telling the patient that you're unsure how to treat this, how about do some more investigating? So we'll start treating that patient from the musculoskeletal aspect. And it, I'm always big on ice outside of therapy. So, but when it comes to fibromyalgia, sometimes ice on the area is going to be painful. So we have to let them know to introduce that slowly. Instead of, full 10, 12 minutes at a time. I want 1 minute. You're going to do it 1 minute the first day, and you're going to do that for 3 days, but you're going to do it 3 times. After that day, you're going to do it for 5 minutes, and you're going to do it 3 times. After that, it's going to be 7 minutes. And once 2.5 weeks go by, if they've been pretty consistent with it, anything you do for 2 weeks will become a habit.
Yeah.
All of a sudden, their symptoms start to decrease. So not that all of their symptoms were coming from the musculoskeletal system, but at least some of them are. And if it decreases what we can do, if it decreases your symptoms 40, 50%, is it worth it? And everybody will say yes,
And
because it's so
fibromyalgia,
bad.
Dr. Randy, that's systemic, right? That's an all over
Yeah.
pain for the most part.
What you feel. Yes,
Yeah, yeah,
absolutely.
yeah.
But
So,
we'll start to treat certain areas, the worst areas first.
okay, that's what I wanted to ask. How do you prioritizing how you treat?
Yeah, because we'll get lots of people that come in and I'll say, well, what's the reason for why are you here? So, well, the shoulder, while I'm at it, it's, my neck. And while I'm at it, I got this knee thing and I got this foot thing. I'm like, okay, hang on, let's focus. Let's do the worst thing first. And if they start to respond, now that becomes secondary. We go to the next thing. As that starts to respond, then we go to the next thing. Just like if we're treating, say, low back pain, and maybe the patient is not responding. But we do a lot of imaging in my office that I'll go through that a lot of places just don't do. That we're treating the low back. All of a sudden, the other imaging, we happen to see inflammation in the neck. So now we're treating both at the same time. All of a sudden, that low back starts to decrease. So now they start responding. So what a lot of places just also fail to do is start. Sometimes the easiest thing to do, or the best thing to do is the easiest, is increase the treatment area. If you're taking insurance, you can only focus on that area to do the treatment, and
Right.
anything after that, the patient has to pay for. But sometimes we just do it because we know it works. Um, it's no skin off our back if we just, even though we may do 7 modalities, but we're charging the insurance 5 modalities, and then we'll just throw the other 2 modalities in there just because we know it works. But sometimes it's just as simple as increasing that treatment area. So it's no different than whether it's a systemic issue or pathological issue. But if it's musculoskeletal in nature, and they see us, they should respond.
Yeah.
So that's the way I look at it. But that's another, and outside of that, um, besides the musculoskeletal, one of our employees is a naturopathic doctor. Because if I'm not really good on something, then, I would love to be able to, bring on people to have another set of eyes on a particular patient.
Randy, define for us what a naturopathic doctor is or does.
So that Dr. Jason in our office, as a naturopathic physician, he's more of like an internist.
Okay.
So he's good with functional medicine and soft tissue. So he's one of our associates, but he also has his own practice in our facility as well. And he treats from the botanical and the nutrition aspect of it.
Oh,
So he helps people get off medications.
nice.
Not just out of the blue. They work with the doctors and all that.
Sure.
But he thinks in terms of natural remedies.
Yeah.
And unfortunately, Illinois, a naturopathic doctor, can't bill through insurance like other states can. But he works a lot with the VA, and the VA happens to accept a lot of help from a lot of physicians that want to volunteer their time. But think about it in terms of somebody that uses botanicals, vitamins, minerals, peptides, and then he's really good with soft tissue injuries. That's why he incorporates that as well. And he just that in itself made him a great fit in our office as that extra puzzle piece that we didn't have.
Yeah.
So he'll think, if somebody's coming in with a particular issue, we're thinking in terms of musculoskeletal. He may think in terms, let's do some blood work, and then let's look through the blood work. So he's got knowledge that I really don't have, because that's his specialty, and then that's what he's been doing for a while. So think of it just the way it sounds. He's more of a natural type of doctor,
Sure.
and we'll start with blood work and the history of the medications currently, and then he'll incorporate his knowledge on musculoskeletal issues and become encompassing with everything, especially since he uses our facility too. It's one thing having the knowledge, but if you don't have the tools, the knowledge can only get you so far.
Right. I want to talk about something that seems to affect us old girls quite often, and I hear it's hormonal, but I can't say for sure. But I hear from women my age, over 50, who are menopausal, are experiencing frozen shoulder, which seems to be kind of a mystery for a lot of us. Do you see frozen shoulder in your practice?
Yes, and think about the frozen shoulder is really no different than any other joint that may freeze. Okay. Remember how your body is dealing with the injury. If you're trying to move a certain range of motion, if it's painful, then you're not going to move to that range of motion. And if you don't go to that range of motion, that's a limited range. So now adhesions will set in. And if you're not going to use those muscles, not only are those muscles going to lock down, but atrophy then sits in. So the frozen shoulder patients that we have, they're two-tier. It's either they're going to respond with a lot of the anti-inflammatory and soft tissue work that we do, or the ones that don't respond, then we recommend you can even do manipulations under anesthesia. I worked at other offices where I've been involved with over 50 or 60 of them, where we go to a surgery center and they get put under, and because part of that not only is adhesions, but there's also guarding. And we've done manipulations under anesthesia, even for chiropractic adjustments. Some people just can't relax. For hips, shoulders, knees. Now that frozen shoulder, if you've ever been involved and been in that room when we open up that soft tissue, it's an awful sound. It's disgusting. Now this is the far end of the spectrum, but come Monday, they're a little bit bruised up, but they have full range.
Wow.
So it's getting past all that. But the problem is we're in pain. So we don't move it, and we'll start to augment our daily activities to not have to move it. And all of a sudden it freezes in that range. How is that different than the same thing happening to the knee or to your pinky finger? If it hurts to go to that range, we don't do it. So we keep ourselves in a pain-free range. Adhesions will set in, atrophy sets in. And that's exactly what frozen shoulder is. So there's no difference between a shoulder being froze or a facet of the spine being froze or your wrist being froze. So your musculoskeletal system, even though our bodies are simple structures, that's what happens. And the response to physical stress and injury sucks, but that's the response. I wish it wasn't. In my opinion, I think it's a design flaw. Sorry, but
We were raised Catholic, Brand. I want to watch what you.
But that's the thing. The response to physical stress is, in my opinion, there's no such thing as a healing response. Okay, of the body. Your body will heal. It just needs to be forced to do so. Okay, why is it so easy to take in certain foods and it goes right to adipose tissue? It takes no energy. To go the opposite direction, it takes a tremendous amount of caloric energy to convert that calorie into actual movement. So, and those are just different metabolisms. So the body itself it would just rather you do nothing, sit on the couch, eat bonbons, and adhese everything. But as we get older, we're not as active as we were when we're younger. So, then when that's the case, your discs will start to thin and your muscles aren't as strong. So even though as you get older, you deal with musculoskeletal issues, one of the big studies that I've seen, 2015, I forgot who put it together, but it was a giant study that it was a reintroduction to a study I saw back in 2007. And it basically looked at colored MRI of patients who were over 70, and the MRI looked at the circumference of the thigh.
Okay.
Looked at the femur and then the musculature around it. And you had one set of patients were very active, ran marathons or were still working, just active people. Then you had the sedentary people. The active people, that muscle, because it was colored MRI, that cross section of that thigh, the muscle was red, thick, the bone was white. The opposite people, the sedentary people, the muscle was purple, gray even. The bone itself was a lot thinner. Now, these people on this side, they were dealing with musculoskeletal injuries on a regular basis. But the pain that these people were experiencing were more pathological. There was diabetes. There was osteopenia, issues with their livers, with their kidneys. So given the two, the old additive of activity is the best therapy. That's really important. So as we get older, we have to stay active.
Yep.
Otherwise that's why if you don't stay active, we get shorter as we age. I used to be 6'1".
Yeah. I lost a half an inch. I used to be 5'5". Like, oh my God. It's starting. It's happening. Oh my
And
God.
it's not the years, it's the mileage.
That's what they say. Hey, Randy, I'm Dr. Randy, sorry. Um, I want to talk a little bit before we wrap up, and I know we can talk about a million other topics, and I'd love to have you back because I'm sure there's plenty that we can talk about. But you mentioned earlier that you've got part of your practice where you are using PRP and stem cell therapy for injury. And I heard about it over the years and I've heard mixed reviews. But why don't you tell us from your standpoint how you use it, why you use it, and what's been successful for you? And
So, yeah, our office, we also have a medical office called Pro Medical, and we incorporate PRP injections. The first thing, what PRP is, a platelet-rich plasma. So what happens is that we draw blood from a patient. We then centrifuge that blood after we add it to a couple of different additives that separates the serum from the substance that's rich in the platelets. Now, what we extract the platelet-rich serum, and that's what we put in a joint that's osteoarthritic, a joint that's injured. It could be into a trigger point in muscle. And what those platelets act as is growth factors. Those growth factors are basically calling the body's own stem cells that are already currently present into the area to start to rebuild the tissue and proliferate.
so are you
Now,
using the patient's own plasma?
yes, we're using their cells, we're
Okay.
using the blood, and we're using the platelets in that blood.
Okay.
Because the platelets act as magnets, so to speak, for the already stem cells that are currently there. Our bodies are filled with stem cells. Once we've developed as a human, now those cells' job is just to replenish the other cells that have lived their life cycle. Okay. And some cells have a life cycle of 45 days, like red blood cells. Other cells have a life cycle of years, like muscle, tendon, ligament, and bone. Now take that life cycle of 4 years and bring it down to 2 months. And PRP works great, but we do what's known as stem cell recruitment therapy. So there are offices that will actually take stem cells, remove them from a patient, or they will use donated stem cells. I'm not too interested in that because there is a tiny element of tissue rejection. And if you're using somebody else's cells in your body and your body rejects it, immunosuppressants and that type of therapy is not a fun therapy. I first looked at it because my body responds very well to cortisone. And years of football and just overuse and a lot of miles, I used to get a shot in my shoulder every year, in my low back every year, in my right knee, in my right ankle. And I felt great. Okay. But if I was doing it for 15 years in a row, it's starting to degrade my tissue. So I was actually the very first injection that we did in my office. So what the stem cell recruitment therapy is a product that's similar to what's known as Palagen and overflow. It's basically when a woman has a C-section, she then could donate her amniotic fluid or her placenta. Some people keep it. But if you decide to donate it, a company, like manufacturers that have these products, they will take that. They would take the growth factors. So they're not live cells.
Okay.
Growth factor. So you're talking about epithelial growth factor, cartilage growth factor. That's basically the layman's terms. And they extract it, store it, and they implement it. It's all sterile. And now you have actual growth factors that can put into the joint. Now you have something that's much more effective than just PRP, although PRP is incredibly effective. But if PRP was the Buick, stem cell recruitment therapy and Palagen and overflow is the Cadillac. That is the cream of the crop. So now all these stem cells that are surrounding the area, because you have a tear in your meniscus in your knee, they're being called into the area. They're going to start to proliferate, build up a scaffolding in that joint, start to reproduce new cells. And now you start to rebuild new meniscus. We've known about stem cells for over 100 years, but prior to the 50s, they were known as pluripotent cells. And the theory was it was their genetic code that determined that stem cell to be a liver cell or a muscle cell or a blood cell. It wasn't until about 1955 where and I forget the name of the physician, but he he coined the term stem cell because it turned out that he put these different cells in different in vitro media. And these cells were in bone media. These were in cartilage media. These were skin media. And all of a sudden those cells became bone, became cartilage, proliferated as skin. So now, it was, that's when it was coined a stem cell, because stem cells all start out the same way. They're all immature cells. It's the environment that triggers them to become the tissue that's needed at the time.
So who's using this type of technology? I'll call it, because it sounds like high tech stuff. And what are patients, I'll say, avoiding by going this route versus, say, surgery or something like that?
Well, right now it's cost.
Mhm.
Okay. And prior to 2020, we were doing it for years. It was actually paid by insurance. And for whatever reason, an insurance company like Blue Cross decided to just stop paying for it. Even though it's FDA approved, and that these cells have been around for over 100 years, and we've been using them medically for over 70 years. But there are offices that use actual stem cells. But again, I didn't want to incorporate that in my office because I wanted it a lot safer.
Yeah.
And we wanted to use the patient's their own bodies to heal themselves. Now, since that's the case, and it's not coming from a big pharmaceutical company, it's not paid by insurance. So the cost is the biggest thing. So, PRP, it could be as much as $1,500 for an injection. Stem cell recruitment therapy, you're looking at about $5,000.
Yeah.
Now, you can go to other places outside the country, or even places, there are a couple places in Chicago that they actually do actual stem cells, but you're looking at costs over $10,000 to $20,000.
Yeah.
You know,
How many rounds do patients usually need to get to some point of healing?
we've recommended 2 injections, but that's over the course of 6 months. I've had plenty of patients that felt great after 1. I've had many patients that actually did multiple joints because they felt great. Every joint that we did felt amazing. Now, I tell them, I go, this is long-term healing. This is not a quick fix, because you need those cells to proliferate. So if you looked on a graph and if you inject that substance, the stem cells will start to proliferate at a very steep angle. And over the course of time, it will start to proliferate less and less and less. And over the course of about 2 to 3 months, you could do it again 3 to 6 months later and hit another spike. So more cells get produced. But typically, most people were doing a joint once a year. They felt great. I've had many patients that did 1 injection and they felt great.
How long does it last?
Well, again, I've had from 2020, I've had people with 1 injection in a particular joint and they still feel good.
Hmm. Okay.
So, and now we're 4 years later. But, we do other therapies as well. You can't just do that. If we're going to incorporate that, we're going to incorporate, an exercise regime and take care of those inflammatory responses as they come up, because we all have aggravations. I wish I could say the patient will never have an aggravation, even if we're treating them. Going forward, here's what you do before you come back to see us. And if it still doesn't work, you get in right away.
Yeah. So you mentioned meniscus, right? What other tissue would it be used for?
It's used for the soft tissue of the shoulder. It could go into near the labrum or into the front of the shoulder if it's the supraspinatus. And if it's in the knee, when you inject a joint, because we use medical doctors that come in that are on our staff that do the injections.
Okay.
We use 2 orthos. One's overall ortho, and one is a foot and ankle surgeon. So all of our foot and ankle people injections are done by that doctor, and they're very specific angles. A knee is either going on the lateral portion of the patellar tendon or in the medial portion. Sometimes you have to go after the popliteus muscle or after that Baker's cyst, or if the tear is in the posterior portion of the meniscus, then they'll come from the back. But typically an injection, even if you go to school to learn how to inject, you bring the needle in, you hit that area bone, you bring it out a little bit, and then you depress that medication. It happens to be that stem cell recruitment therapy. So shoulders, we've done it in elbows, ankles, knees, plantar fascia. We've done it in
I need to come see you for that. I can
soft tissue. It's
You know-
amazing.
you know
That's the
how-
trigger point.
You know how many dancers I could send to you for plantar fasciitis problems? Well, I was just at a dance over the weekend, and there's like 3 of us girls talking about how the fasciitis is getting worse as time goes on, but dancers will dance through pain anyway.
Absolutely.
So,
You're like, it's just like any other athlete. But when you start, the problem is your foot is the foundation of everything. If you remember how many bones are in a human body, 206. In the foot and ankle, there's 26.
yeah,
So it's a quarter of all your bones.
yeah.
It's pretty important. So that plantaris muscle on the bottom of the foot covered with that fascia inflames. But every time you take a step, it's going to be painful.
It's so
So
painful, and I feel like when your feet hurt, everything hurts, and then you don't wanna do anything, then you're sitting around on your butt because it hurts too much to walk around, especially in the morning, so, yes.
always ice it. And then if that ice isn't doing the trick, now you got to get it treated. We get our plantar fascias back a couple weeks. So a good 5-6 visits.
Wow.
And then we start to incorporate the exercises, but then we'll also put them on our 3D foot scanner. So a lot of places will do foot orthotics. At our place, we have a 3D foot scanner. So it's weight bearing,
Hmm.
and it takes an image of the foot while you're weight bearing, and it shows exactly where you're putting your pressure down. Most podiatrists, for whatever reason, they still use this foam, and they'll put your foot in a foam. Now, back in 1958, that was brand new technology. So the problem is you put your foot in a foam, they send the foam to the orthotic company. The orthotic company makes a mirror image of your foam. How does that help your biomechanics? It doesn't. And for whatever reason, podiatrists love giving people rigid orthotics.
Yeah, they're terrible too, and they're expensive, they're like $60 for one pair, and I thought, "I'm a girl, do you know how many pairs of shoes I have?" So,
Yeah, and it's usually covered by insurance at our office. But the thing is, you
You
can't
know
use a
what?
rigid
Mine
orthotic.
wasn't. Mine wasn't. My orthotic wasn't even covered with Blue Cross through a podiatrist. Do you believe it? Yeah.
That
Mm,
maybe they just didn't go through the proper ways of doing things.
maybe not.
Because,
I
well,
told
that's
her.
the thing. If you don't have objective findings, because all you have is the doctor's note and you have the imprint, the 3D foot scanner generates an algorithm score
Mm,
based on where you're putting your pressure. It measures arch height, center of gravity, and the higher the score, the worse your feet are. The worst feet that we've ever had the score is our NBA athletes that come to get these, and their feet are terrible,
I
you
bet.
know? And a lot of times their orthotic is different right foot versus the left foot.
Well, it sounds like you have a lot of cool toys to play with over there, Dr. Randy, and I think it might be worth the drive for me to come out by you and just see your place and take a look at this fasciitis problem and like 5 other things I could probably have you look at. But any final thoughts or advice you would like to give to our listeners before we wrap up today? This has
Yeah,
been
just
so
make
cool.
sure, yeah, number one, make sure always, no matter who you see, any healthcare provider, always question the authority if things don't gel with you. Okay. Or if things are not getting better, you bring it up to them. Why why do I always talk to new patients that come in and say, yeah, I was in physical therapy for 9 months, or I was in a boot for 18 weeks,
Oh,
how 4 weeks, um, 12 visits, that should be it. And if you're not feeling better within half that time frame, you bring it up to that healthcare provider. What else can we do? Okay. I think what we're doing is not working. Every time I come here, I'm in pain. Always question your authority, except me. Don't question.
that's
No.
don't
But
question Dr. Randy.
I even recommend my patients, hey, question it. If you're not feeling better, we need to know. Because if you're either going to respond to the therapy or you won't. If you don't, we'll change it up until you do respond. And if we go through everything and exhausted all of our therapies, well, they're probably not going to get better. It's the next step.
Yeah.
Also, it's very important. If you're a parent of an athlete, multivitamin, make
Mm.
sure the kids are taking a multi. A simple multi will do. Their protein intake is important, water intake. And one of the other things that our office specializes, we don't specialize in, we just happen to treat, is a lot of concussions.
Oh, I'm
Concussion,
sure. That's huge
concussion
with
treatment
the kids. Yeah. Mhm.
time. Concussion treatment, we do baseline tests for all the programs that we are affiliated with. So we have something to go by, but the treatment of concussions, and every place out there will say that they treat it. But the only treatment that should be done is what's generated by the International Concussion Committee. They are the ultimate authority on planet Earth of where everything, all the research goes to, all the treatment comes from. What the NFL and the NHL do, they do International Concussion Protocol. Prior to COVID, there was maybe 4 offices in the state that were certified in it. Now, I don't know what happened to them.
Mm.
If somebody was certified, I didn't know who they are. And I talked to neurologists who are call themselves concussion specialists, and they can't even tell me when the last International Concussion Committee met. They meet every 2 years at, a place like Paris or Montreal, whatever. But that old additive of if you go to the kid's pediatrician and they say things like go in a dark room, that's all passé. That has been debunked. Um, Mental activity is the best. And as an adult, if we get hit, it's completely different than if a teenager is hitting the head. There's a 5 to 7 day window. There's a whole bunch of things that parents just don't know once they come in, because they know that we already work with that particular program. We happen to see a lot of them, or they've heard about us. We go over what to do, what nutrition to do, the activities that they need to do. Obviously, we'll give them a note for school and all that, and then we'll monitor them. And then the treatment, we do exactly what the NFL does and the NHL does. But not all NFL professional programs are created equal. But there is laser right where the head got hit, particular frequencies. We treat the neck because there's whiplash, but there's also an acupuncture protocol, and it is extremely effective. I mean, we have 8-year-old cheerleaders that do an acupuncture protocol. It's designed to help the brain waves, but man, is it effective. And we treat over 150, 160 concussions every year.
Wow.
So yeah, it's just look out for that. Head injuries are a big thing nowadays. And now's the time where we're seeing, I just had 7 of them came in last week. They're not all concussions, but that's the thing. It's not so much, they're called minor traumatic brain injuries. They're not injuries to the brain as much as they are jolt to the nerves.
Sure.
I show parents or anybody that comes in, here's what's going on. Here's what happens in the central nervous system. So they can see, and then I give them the instructions what to do at home. And they need to be mentally active. If they're not a reader, that athlete, they're going to look at magazines. They're going to play board games. They're going to draw, color in a coloring book. I don't care. And you only avoid the things that bother you. You don't avoid everything. Too many times they go to the ER. The ER checks your insurance. Oh, let's do an MRI. Let's do a CT. And they're going to tell the parent, I hear this a lot. Oh, we didn't see the concussion. You're not going to see the concussion on any imaging. You can see hematomas, that kind of stuff, but that's, they do it way too much. So again, the moral to the story is question the authority and make sure if what you're getting done is not working or if it's not gelling, ask questions.
Cool. Well, Dr. Randy, thank you for all of this amazing wisdom and knowledge. It doesn't sound like you're going on vacation anytime soon either.
It's hockey season.
But so what do you think? Do you think now that we're getting older, we should be doing 5-year reunions instead of 10?
Hey, I saw some people at the reunion like, oh my God, I thought you passed away.
That's like, my God, I know, right?
No, this has been a treat. I love just the whole essence of the podcast, Desperate for a Diagnosis. When you asked me to be on, I'm like, man, what a great concept. And I basically built my practice around that, the whole element of that. And you get a lot of people that are on here. It's very cool. It's very knowledgeable. I want you to keep up the good work.
Aw.
You're awesome, and you need a voice out there, because if it's not you that's doing this, where are people going to go? Where are other people going to question the authority? All right. So keep doing what you're doing, keep fighting the fight.
Thanks, Randy. I appreciate that. And I'd love to have you on again because, like I said, I think there's probably 50 more things we could
Let's do it.
talk about. So yeah,
I love it.
do it again.
This is great in here. This is
Yeah.
a cool environment in this
That's-
little podcast. Never been in a podcast. That's cool.
That's right. That's great. Well, so glad that you joined me, Dr. Randy Cybulski. And again, the name of your practice, Randy, and your website, please.
Pro Sports and Spinal Rehab out in Plainfield, Illinois.
Yep.
And the website is prosportschiro.com, prosportschiro.com. And then we have a gym in Naperville, Illinois, forcegymnaperville.com.
Awesome. Awesome. Well, thank you again, Dr. Randy, and we'll be talking again to you at some point. Again, that's Randy Cybulski, my grammar school friend. Who would have thought? Who would have thought? All right, everyone, this is Laura Nozica. Thanks so much for joining us today on the Desperate for a Diagnosis podcast. And Stay well, everyone, and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.